Hey everyone, welcome to this explainer. Look, if you've been online lately, you've probably seen a ton of noise about vitamin D. Today, we're cutting straight through all of that to break down the fascinating biological journey and clinical realities of this hormone. We'll look at how it actually works, what really happens when you don't have enough, and how medical professionals treat it. Let's dive in.
Here's our clinical roadmap for today's explainer. We'll start with the sunshine hormone, move into bones, muscles, and metabolism, then look at the anatomy of deficiency. After that, we've got real patients and real cases, diagnosis and treatment, and finally, we'll clear up some myths, facts, and prevention.
All right, let's jump right into Section 1, the sunshine hormone. Where does it actually come from?
So, you know how we call it a vitamin? Well, actually, scratch that. It doesn't act like a typical vitamin at all. It's really a powerful hormone precursor, and we get it from two main sources. You've got vitamin D2, which mostly comes from fortified plants and plant-based drinks. Then you have vitamin D3. That one comes from animal sources like fatty fish and egg yolks, and of course, the most famous way, synthesized right in our own skin when we step out into the sunlight.
But right off the bat, we've got to address something super important about that whole sunlight connection. Yes, UVB radiation triggers that amazing synthesis of vitamin D3 in our skin, but you guys, more is absolutely not better here. Safe sun exposure is great, but intentionally baking yourself in UV rays? No way. That actively increases your skin cancer risk. It's why medical guidelines are crystal clear. Excessive sun exposure should never, ever be used as a medical treatment to fix a deficiency.
Moving right along to Section 2, bones, muscles, and metabolism, the biological journey.
I want you to think of your body like a highly advanced, giant manufacturing plant. Step 1 is getting the raw materials. Your skin synthesizes vitamin D3 from UVB radiation. But it's not active yet, so it ships that raw material off to Step 2, the liver. The liver converts it into something called 25-hydroxyvitamin D. Still not done. Finally, Step 3, the kidneys take that compound and upgrade it into its highly active hormone state, calcitriol. If any single part of this three-step factory breaks down, skin, liver, or kidneys, the whole system just grinds to a halt.
So why is this whole factory process so critical for us? Because vitamin D is essentially the invisible force keeping your physical foundation solid. Once the kidneys give it that final upgrade, this master regulator teams up with calcium and phosphate to properly mineralize our bones and literally power our entire neuromuscular system.
Which brings us to Section 3, the anatomy of deficiency. What happens when the system breaks?
First things first, we need to define our terms here because, well, insufficiency and deficiency are not the same thing. Insufficiency basically means your levels are suboptimal. You might not feel any immediate symptoms, but your tank is running a bit low. Deficiency, on the other hand, is a severe drop. We're talking active impairment of bodily functions, like bone mineralization and muscle strength. The tricky part, clinical guidelines actually vary on the exact cutoffs for these numbers. This is exactly why your vitamin D status always needs to be interpreted in a full clinical context by a pro, not just treated as some universal one-size-fits-all number. So, with all these moving parts, skin exposure, diet, liver processing, kidney activation, there are clearly a lot of ways this pathway can get derailed, which begs the question, who is actually at risk for this kind of breakdown?
While the risk factors are incredibly diverse, older age and darker skin pigmentation can naturally reduce how much vitamin D your skin synthesizes. An indoor lifestyle or limited mobility, that drastically cuts down on your Step 1 raw materials. Then there's obesity. Since vitamin D is fat-soluble, it can actually get trapped in adipose tissue. You've also got gastrointestinal issues, think celiac or Crohn's disease, which cause malabsorption, meaning even if you consume it, your body just isn't absorbing it. And of course, if someone has chronic kidney or liver disease, that directly impairs the whole factory machinery from making that active hormone.
When a severe deficiency really takes hold, it attacks our structural integrity. This directly causes osteomalacia. That's a defective mineralization and softening of the bone, which, in kids, manifests as rickets, leading to bone deformities like bowed legs. Now, notice this is completely distinct from osteoporosis, which is a reduction in bone mass and deterioration of the bone's microarchitecture. They often interact, sure, but they are absolutely not the same disease.
All right, Section 4, real patients, real cases. Let's play clinical detective.
Let's look at how this plays out in the real world. Take a 35-year-old adult experiencing muscle weakness and bone pain. Their plan is going to involve testing, targeted supplements, and exercise rehabilitation.
Now, compare that to a 70-year-old adult. Their primary symptom might be limited mobility and a really high fall risk. So their treatment relies heavily on combining calcium with very specific balance and progressive resistance training. Then we have a child with rickets. They require careful imaging and long-term monitoring of bone growth. And finally, remember that celiac patient? They might be taking standard supplements, but still remain deficient because of malabsorption. You can't just throw more pills at them, you have to treat the underlying gut issue first. The takeaway? Treatment is never just a one-size-fits-all situation.
Section 5, Diagnosis and Treatment. Let's look at the clinical guidelines.
Given how incredibly widespread deficiency is globally and how many vital systems it impacts, you'd probably assume that universal routine testing for everyone is just the standard answer, right?
Well, actually, the medical guidelines explicitly say otherwise. Routine testing of every single healthy person is not necessary, nor is it recommended. Instead, screening really has to be based on specific clinical risks. When doctors do test, they use a blood test called serum 25-hydroxyvitamin D. But they reserve this test for people who are actually exhibiting clear symptoms. Folks with metabolic bone disorders, those with malabsorption issues, or patients taking specific medications like anti-seizure drugs or glucocorticoids that mess with how vitamin D is metabolized.
And when a deficiency is officially diagnosed by a clinician, the treatment is highly comprehensive. It's a full multidisciplinary package. We're talking tailored vitamin D3 or D2 supplementation, no guessing at doses here. It requires assessing your calcium levels and kidney function to ensure the whole system is firing correctly. It involves dietary adjustments to get more natural sources on board. And crucially, just like we saw in those patient cases, it includes physical therapy. Things like progressive resistance training, functional balance exercises, and weight-bearing activities to actively rebuild that musculoskeletal health. It is never just popping a pill, it's a total physiological rebuild.
Finally, we arrive at Section 6, Myths, Facts, and Prevention. Time to clear up the confusion.
Let's just clear the air right now. More vitamin D is not always better. Taking massive doses isn't going to magically cure obesity or routinely prevent every single chronic disease from cardiovascular issues to depression. What the evidence actually backs up is this. It is absolutely essential for calcium absorption. Severe deficiency truly does cause real bone diseases like rickets and osteomalacia. And supplementation has to be clinically individualized.
That pervasive myth that more is better leads to a very serious clinical reality: toxicity. Because vitamin D is fat-soluble, your body stores the excess. It doesn't just neatly flush it out like vitamin C. Self-prescribing massive, unmonitored doses can lead to hypercalcemia, which is dangerously high calcium in the blood, and trust me, you don't want that. It causes severe nausea, vomiting, excessive thirst, and eventually painful kidney stones and severe kidney injury. Toxic buildup is a very real, very dangerous risk.
So we're going to leave you with this critical question. With all the conflicting information out there right now, are you getting exactly the right amount of vitamin D your body needs based on your unique risk factors? Or are you just guessing based on some internet trend? Do yourself a favor. Talk to your healthcare provider, investigate your real clinical risks, and please don't let internet myths dictate your health. Thanks for hanging out for this explainer, and keep asking the right questions.